Thanks so much. It's really wonderful to be part of this conference and to share with it. And as you've heard, I was a pro bono expert witness in the Heidi Crowter case, and these issues are very close to home for me as a pediatrician, and it's wonderful to be here. And I have to say that also, as a clinician and a physician, I almost feel like I have to apologize on behalf of my profession, because there's so many accounts, which I've heard here, but I've heard many others from other people, of terrible, insensitive, paternalistic, coercive, demeaning contacts with senior highly trained doctors and specialists. And it's worth just reflecting for a moment on the fact that there is nobody speaking at this conference who is a senior fetal medicine specialist, obstetrician gynecologist, ultrasonographer, senior midwife. And it's fascinating to ask, why not? It's like there's just a huge blank. And there are many answers to that question, why not? But one answer to the question is that actually the UK senior medical profession there are certain areas that have become extremely hostile to professionals who do have a pro-disability or quotes pro-life orientation. And in fact, I cannot think of a single senior obstetrician, a gynecologist, fetal medicine specialist, who would publicly take a pro-disability stance in the UK. And that in itself is fascinating, and it reflects the fact that there are many other physicians like myself have chosen different career pathways because practicing obstetrics or fetal medicine would be seen as just too hostile. But interestingly, that isn't true in the States, for instance. In the States, there is a very active association called the Pro-Life Obstetrics and Gynecology organization. And I think it's interesting to reflect why that hasn't happened in the UK. I am aware of a whole generation of young women, female, who are training currently and planning to go into obstetrics and gynecology, who are very strongly orientated pro-disability and pro-life. And I hope they will transform the attitudes within the profession as we go into the future. But it's interesting to just reflect on the current experience. I went into neonatology because I love children, and I ended up working in caring for newborn babies in a big intensive care unit in central London at UCH. And then I was shocked to discover these two areas of the hospital, as Sarah has outlined it at the JR. So we were in the neonatal intensive care unit, where we were very committed to giving the very best chance of life to very sick and some severely abnormal, deformed babies, some extremely preterm babies. And yet just one floor up in the fetal medicine unit, Latefeticides were being carried out well beyond 24 weeks, 26, 28 weeks, 30 weeks and beyond. And on numerous occasions later on in my career, I was called up as a senior neonatologist to go and talk to a mother who was considering, who had been offered a Latefeticide, a termination, and to discuss with her what the options were and so on. And the baby in her womb was considerably bigger and tougher and stronger than many of the babies we were caring for one floor down. And you ask yourself, how is it possible in one NHS, in one hospital, for these apparently completely contradictory activities to be going on? And again, it's just interesting to reflect that it's practices like that, which in some way send the messages, as Sarah put it, about attitudes, about what it means to be human. And so I've had a lot of the privilege of talking to parents in Sarah's condition and many others where parents are trying to respond to a diagnosis of a life-limiting fetal abnormality. We tend to use the terminology of life-limiting rather than fatal because it reflects the reality, first of all, that there's a huge range of very rare conditions, and they vary between those who are incompatible with life, that invariably lead to stillbirth or death within minutes, to those in which death may occur over minutes to weeks to months to years after birth. But secondly, the life expectancy of babies with these life-limiting abnormalities actually depends on how they're cared for. So if it becomes a self-fulfilling prophecy that if you provide no resuscitation at birth and no attempts to help the baby will die much more rapidly, whereas in conditions such as trisomy 18 or Edwards syndrome, some children will live for months or years if they are provided with basic life support and care at birth. So, unfortunately, for many clinicians working in obstetrics, fetal medicine, and genetics, termination or feticide does seem the rational, obvious, decisive, progressive solution. And we've heard the reasons why from Brian Brock and others. Oh, sorry. And when parents say they wish to continue the pregnancy, unfortunately, what then happens is the professionals often adopt, consciously or unconsciously, a number of strategies to coerce the mother. And the ways they do this, just very briefly, they can emphasize the pain and suffering that's being caused, either the pain and suffering to the mother or to the baby. They describe the malformation in gruesome and insensitive terms, dehumanizing the baby. They emphasize the risks of continuing the pregnancy to the risks of the mother's health and future fertility. They imply that parents are being irresponsible or selfish and that there's some form of moral duty to have a termination. And they offer to perform the termination immediately in order to stop the distress and quotes, fix the problem. And so again, this is, we can do it straight away, you don't need to worry about it, and so on. And yet my experience fits exactly with what Sarah says very movingly about her own personal experience, that following a diagnosis of a fetal abnormality, or particularly of a life-limiting abnormality, most parents are shocked and confused, disempowered. They find themselves in a painful and emotionally charged situation that they'd never imagined. And a common question that parents ask themselves is, how do other people act in this situation? How do other parents respond? And because they're in this completely new landscape, this completely unexpected, they've never thought about this before, and they are suddenly in this weird and strange landscape, they're wide open to implicit suggestion and manipulation from the professionals who have been here before. And in my experience, it's particularly the case when the possibility of late abortion or feticide is raised. So sometimes a diagnosis is only made late in the pregnancy, sometimes at 32 weeks, 34 weeks. And bizarrely, in that situation, the doctors will perceive that they have no choice but to raise the possibility of late feticide. Because if they don't raise the possibility, they can be sued for so-called wrongful life. But once the possibility has been raised, here is a woman who is heavily pregnant, 34 weeks, and so on, everything. She's been looking forward to the birth of her child. And now the doctor is offering her the possibility of a feticide. She is horrified and appalled that it's even legal. But now the fact that it is apparently legal means that that must be what society has decided is an appropriate response in this situation. And I remember vividly one mother having discussed at length, and I hope sensitively, about the reality of the possibility of a late feticide. She said to me, "You know, doctor, you just put me in this completely impossible situation. Either I am responsible for bringing a very severely handicapped child into the world, and I carry that responsibility, or I am responsible for killing my baby. I mean, what possible choice can I make?" Whereas if you told me after the baby was born, I would be shocked, but we would have got on and cared for the baby. But now you've put me in a completely impossible decision. And yet, paradoxically, the doctor says, "But I have no choice. I have to put you in that decision." That's again how the system, the practices, promote in themselves some deeply painful realities. The bizarre thing, again, and this is where doctors do an extraordinary doublethink. In the rest of medicine, we have all been deeply imbued with the importance of informed consent, and therefore ensuring that parents are given extremely careful and detailed information, particularly if a surgical procedure is being proposed, so that mothers, patients can make the most careful and detailed assessment of balances and risks and so on. But all of that goes out of the window when we're talking about abortion. The normal rules about consent and information don't apply to abortion. At least that's the doublethink that goes on in the doctor's head. And when you say, why not, the answer is because it's abortion. And abortion is a moral right that people have, and it's deeply insensitive to raise any issues or problems. So doctors will not talk about the possible complications of an abortion procedure, or about the possible psychological long-term consequences, even though all that is well documented in the literature. And when asked why not, they say, well, that would be deeply insensitive to raise these questions. It would be paternalistic for me to do that, quote. So there's this extraordinary doublethink that in the rest of medicine, we must give very carefully balanced information to help people to make informed consent. The one situation where as medics we don't do that is in abortion. And so, of course, to apply coercive and manipulative pressure on parents who are in this highly vulnerable, confused and disempowered position is highly unprofessional and highly unethical, and yet it goes on the whole time. It seems still that it's common. I think there is a slow change. I think there are slow improvements, and it's happening in some hospitals more than in others. But it's still the case. I still hear regularly similar stories, even in 2022, I have the privilege of supporting a number of women with life-limiting abnormalities with unborn babies. So, however, there is a growing realization amongst professionals that there is a positive alternative to a termination with a life-limiting abnormality, and that is caring for the baby, supporting the mother through the pregnancy, and then providing supportive and palliative care once the baby is born. And over the years, I've had the privilege of caring for many babies with these abnormalities who've been born and providing palliative care. And it's been one of the most wonderful experiences of my professional life. And it's interesting, as a neonatologist, I must have cared over the years for maybe thousands of babies who've gone through the neonatal unit. And yet, it's the small number of dying babies and their families that I remember still, and that are imprinted on my mind. as something, a very wonderful, painful, and yet wonderful experience. And it's, again, the contrast between what happens in a feticide and what happens if the baby is born is very stark. And it's interesting to see the psychological differences. So when there's a feticide, often occurring at a very late stage of pregnancy, the natural instinct of mothers and parents and families is to keep everything quiet. And therefore, there's no discussion, even if a friend says, well, you were pregnant last week and you're not pregnant, what happened? I can't talk about it, I'm sorry, it was terrible, it's private. And so there's an obscure sense of loss and shame, and only a very small number of trusted individuals can be let into the secret of what actually happened. Parents may not wish to see the body of their aborted fetus, and they're less likely to want to spend time. And the contrast with that about what happens when a baby is born, even if that baby only lives for minutes or is born stillborn, but particularly if the baby lives even for a short time, everybody knows that it is a public event. The family, the extended family, friends, cards come in, people come and visit, photographs are taken, footprints, celebrations, services, and there's a whole social context. So that as we go on into the future, yes, there is grief and there is loss, but it's done within the social context of everybody else who met the baby and everybody else who remembers the baby and supports the parents. So it's a very different experience, and there's no doubt that, of course, both the experience of a late feticide and the experience of losing a baby at birth or in the first few hours or days is extremely psychologically stressful and wounding. But again, I'm interested in the differences that I've observed in the psychology between those who had a late feticide and those who continued the pregnancy. With termination, there's often an initial sense of relief, but it's often accompanied by some kind of ambivalence. Did I do the right thing? Was I being selfish? Maybe the doctors got the diagnosis wrong. Maybe the baby wouldn't be as bad as they thought. I wonder what the baby would have looked like, and so on. And it's not surprising that several studies have shown very high levels of long-lasting psychological distress going on months and years after a late feticide, and also both for fathers as well as for mothers. Whereas the psychological response to losing a baby who then dies is very different. Again, there's great sadness and a devastating loss, and Sarah has talked so movingly and written about it in her book, which I strongly recommend, The Shaming of the Strong, or Perfectly Humans, I think it's now called. But parents have a sense that they did everything possible they could for their baby. They were there for their baby. And there's none of that ambivalence which I have seen. And also a desire to celebrate the life of their baby. And it's interesting that whereas often other people forget that that baby existed, the parents never forget. My experience is years or decades later, you say, how many children have you got? Oh, we had 3 children, but one of them died. And that child always remains part of the family, one of the to be celebrated and remembered. So I just want to move to the idea of the expert-expert relationship. So it seems to me we've got these two paradigms. On the one hand, we've got old-fashioned medical paternalism, which we all can see why it was so unhelpful. But the converse, which is the kind of client-technician relationship, where the professional offers options and choices, and it's the client who has the agency and who makes choices, is again very unhelpful. And I think that an alternative model, which sees it as an expert-expert relationship, is much more helpful. It's a collaboration, a collaborative model of a doctor-patient relationship. And the physician, the professional, has expertise in the diagnosis, in the prognosis, in the treatment options that are available, and so on. And not only that, hopefully the physician brings not just clinical expertise, technical expertise, but also the essential virtues of the physician, which are or should be wisdom and compassion and empathy and humanity and moral integrity. But parents have expertise too. They too are experts. They're experts in their own family background, in their own history, in their own values, in their own beliefs and concerns. And so expert-expert relationships work best when there is mutual respect and concern. And I expect parents to respect my expertise as a professional and as a neonatologist, but I must respect their expertise in their family, in their concerns, in their values, in their history, and so on. And Mari Tidball yesterday described her interaction with the one obstetric consultant who seemed to respond appropriately, and she said, he was a human that saw another human. And I thought that was a beautiful description, and that's exactly how I also try to think it. Instead of saying, I am the doctor, I'm the professional, I'm the expert, and you're just the patient, you're the one, you're the supplicant, you're the one who needs help. Instead, we are the same, you and I. We are both human beings. I too know what it means to be in pain, to be anxious, to be vulnerable, to be confused. And I'm here to walk alongside you as a wise friend. So together we try to find agreement on a way forward, a consensual decision which meets both our expertise. And the quest for consensus requires honesty, it requires openness, it requires humanity, it requires transparency. And sometimes there is a process of negotiation, a process of compromise, where I feel this would be very much the best, whereas the other person says, no, I think this is the best. And then can we collaborate together and find a way forward? And I've concluded that one of the essential characteristics that the physician must show, both for the parents but also for the dying baby, is respect. Respect for the essential dignity of the human person, and especially for the baby, however malformed and distorted they are by the consequences of disease. Parents are very sensitive to pick up the vibes of how the professionals are treating their child or how they themselves are being treated. And if they sense an attitude of contempt or indifference or repugnance to their child, that's extremely hurtful. So we can communicate an attitude of respect by spending time, by listening, by touching and cuddling the baby, by handling the baby with the parents in a respectful way, by our words, by our actions. And so here are some common parental intuitions about the dying or malformed baby, which I've sort of picked up. My baby is a unique individual to be named, loved, and treated with respect, a person, not a thing. Although my baby may have limited potential for future development, he or she is not disposable and can never be replaced. If my baby has no prospect of surviving, it may be appropriate to allow nature to take its course. That's a phrase which we often use and which I think people intuitively understand what it means, to allow nature to take its course. But this is intuitively different from intervening to kill or actively ending the life of my child. If my baby dies, the reminders, the physical reminders, the memories of his or her existence are of unique significance and importance. And although I may have future babies, they can never replace the unique individual I have lost. So I would conclude that actually neonatal palliative care does provide a realistic, compassionate, compelling, and practical alternative to termination and Latefeticide with a life-limiting fetal abnormality. And I argue that it should be promoted and celebrated as a life-enhancing development within modern medical care. However, unfortunately, at the moment, neonatal palliative care is patchy, and it's sadly true that many parents given a diagnosis of a life-limiting fetal abnormality are not informed about the possibility of high-quality palliative care. So there's a major task of education. We need to transform attitudes both within and without the profession, and to ensure that a baby dies at peace, pain-free, and supported by his family should be seen as a triumph of modern neonatal care. Thanks very much.